Thank you, everybody. As everybody's joining, we're just giving just another minute just for everybody to register coming through. We've got more than 100 people registered, which is excellent for the first Pan London event. So fantastic. Warm welcome to you all. All right, I think we've got quite a few people registered now, and it's being recorded, and it's a jam-packed agenda. So I'm going to make a start. So welcome everybody. I'm Sophie Russell. I'm a consultant midwife at Lewisham and Greenwich, and I'm also the clinical lead for the Safety and Improvement programme. So welcome. This is the first Pan London maternity neonatal safety improvement programme event that we're putting on, and we really like to hear your feedback at the end of the event. So we've got a really great agenda lined up. So just before we go through the agenda, if I could just ask, and I think everybody's got their mics off, which is great. If you haven't, if you don't mind just muting, just because when the speakers are presenting, sometimes you get echo. This is very much an event for everybody that's joined today. So please feel free to ask any questions. At the end of each presentation, we've got 5 minutes for questions, and we really want this to be an event for everybody where we can take away ideas, come away with quality improvement programs. We know that maternity and neonatal environment at the moment is it is challenging, to say the least, so it's really great to hear all of these improvement ideas, and we want to hear yours as well. So I think just keeping an eye on the time, because I'm notoriously bad. So we've just got another minute or so. So I'll just give everybody a minute coming in. There's more and more people coming in, which is fantastic. And as I say, it is being recorded. So if any of your colleagues have got clinical commitments and can't join, please do let them know, and they will be able to watch this back. And I'm sure Gemma will be able to send out the link again afterwards to everybody. So just quickly running through the agenda so you know what we're going through today. So we've got an update from Charlie Myrick. This is on the national update on the deterioration. And we've got optimization from Olivia Houlihan. That's right place of birth, and that's really timely at the moment. Optimization for delayed cord clamping. We've got optimization of development and delivery of preterm birth, health inequalities, and we've got a panel discussion as well. And we would really encourage you to join that panel discussion, and that's on addressing the challenges of improvement in this the difficult sort of midwifery and obstetric staffing crisis that we're in at the moment. And then we've got closing statements at the end. And as I say, it's really a confidential space for all of you, and we're really looking forward to hearing your ideas as well. So I'll hand over to Charlie to take us through the first presentation.
Do we have Charlie on the call? Charlie or Hannah, maybe?
Okay, not to worry. Whilst we're just waiting for them to come through, I I don't think we can talk about a maternity and neonatal safety event without talking about the Ockenden publication that happened last week, and I'm sure you're all very familiar with the reports now. And I mean, I think reading the 15 immediate and essential actions, I think that they're all great for maternity and neonatal services. And sorry, got distracted by my phone there. I think they're great for all of our services. And I think we, somebody's desperately trying to get hold of me. I think we need to think about how do we sustain the improvement culture when we are going through that staffing crisis at the moment. And I think some of the the actions do seem slightly unreachable when we have got a staffing crisis, but there's just very small things that we can do. And that's the sort of purpose of this agenda, to talk about those improvements that can make for patient safety and also your working environment slightly easier. So I don't know, have we got Charlie on the call? Has Charlie joined? Sorry, it was always tech, wouldn't be a Zoom or Teams meeting without tech issues.
We've just emailed him. He's not here yet, I don't think.
Have we got Olivia on the, Olivia? She's our next speaker.
She's just sent a Teams message, if you can see it.
Okay, let's have a look.
Or I can read it for you, but I'm sure it's there. I'm Jen Loudon, I'm the Labour Ward lead at St Helier and Epsom.
Hi, welcome, Jenny.
Is Hannah on the call?
I know a few colleagues might be in the Teams chat. I wonder if Charlie or Hannah might be on the Teams. Let me log into that and see if they can move over to the Zoom. Give me 1 second.
Thank you. So sorry about that, everybody. So I think just for filling in a couple of minutes whilst we're waiting to resolve our tech issues. I was just, as I say, my reflections on the Ockenden report. Again, we can't do a maternity safety event without talking about it. And I think, you know, obviously what happened at Shrewsbury and Telford was really challenging. And the report is really aimed at all of us, not just Shrewsbury and Telford. So it's reading the report through the lens that these recommendations are for all of us, and that's exactly what they are. And I think we've just got Charlie's joined now.
Hi everyone, I'm so sorry I'm a little bit late, I do apologise.
It's all right, we were just filling in talking about Ockenden, so I'll hand over to you. Thank you.
No problems, and thank everyone for letting me come. I believe my colleague Hannah is somewhere on the call as well, I believe. Hannah?
I'm here.
Oh, lovely. So hi, for everyone that doesn't know me, so my name is Charlie. I'm one of the senior improvement managers for the Maternity and Neonatal Safety Improvement Programme, and I'm joined by my colleague Hannah. Hannah.
Oh, hi, everybody. I'm Hannah Rutter, and I am leading on the deterioration workstream for MatNeoSIP, working alongside Charlie.
So thank you very much. If I could just have the next slide, please. So Hannah and myself are just going to do a little bit of a duo on this. So just going to give you a little bit of a national overview of some of the work that we're currently doing in this space. And then Hannah's going to do a little bit of a deep dive into the deterioration workstream, looking at the Muse and Newt 2 tool as well. And I'll very much let her take that forwards. So obviously, just to kind of kick things off, we very much have just released our 2022-2023 specification, for which I'm hoping doesn't really have any sort of major surprises in it. You may remember that we were doing some work in the smoke-free work stream. Then there's obviously, but we're no longer taking that forward. So there's obviously some plans in place to help support with the transition of that work over to our public health colleagues, which I'll talk a little bit more about later on. But again, we're very heavily involved in the preterm optimization work stream, along with the deterioration work stream, which, as I say, will look at the sort of implementation of the new national Muse tool, so the maternity early warning score, and the Newt 2 tool. And then I suppose finally, one of the sort of the new adaptations of the specification that we've got is we're very much looking at a more outcome focused work that's more outcome focused. So again, really sort of touching on the outcome measures and outputs of doing a lot of this improvement work that we're leading across the system, and working very closely with our London colleagues and nationally as well. So it's quite an exciting sort of adaptation to what was normally a slightly different approach. So going into sort of final stages of a return on investment framework. So one of the things that we are really looking to help build on those outcomes is sort of return on investment. And this kind of has two components to it really. So the framework that we're looking to create will help support patient safety collaboratives in articulating the impact of patient care. And then there's also a subsequent component to that, which will start to look at any subsequent savings additionally to that as well. So the framework very much will include things like patient stay, types of treatments, but also the impact to patient care. So reduced mortality, improvements on patient outcomes. And a lot of that is referred to the BAPM toolkits that we're very much aligned to and have been working very, very closely on. So once we've finalized this framework, we'll be doing a sort of, a bit of a presentation on what that will work and how you can use that so that you can help devolve that information down to sort of local level. We have been working collaboratively with NNAP, National Neonatal Audit Programme, to really help align a lot of our measures. So within the preterm optimization work stream, obviously we've got 7 key interventions, and again we've been looking to help align those measures with NNAP to really support nationally everyone sort of collecting the same measures, especially around the sort of gestational periods, and also help reduce the data burden from the system, and we're really hoping that will help support organizations and systems in their sort of data collection, because we do appreciate that is obviously quite a difficult thing to do. And then finally, as again just sort of reflecting on the smoke-free work, obviously we've been working with some wider stakeholders, especially within the sort of our public health colleagues, in looking to sort of hand over with the PSCs all of the fantastic work that has been undertaken in reducing the prevalence and incidence rates within the pregnant smoking. And what we will be doing is we'll be sort of collecting some of these transition plans nationally and sort of bringing those all together. And we do have a session on that tomorrow within our workstream leads meetings, and we'll be helping to support the system in maintaining and holding all of the gains that have been made, but then also handing those over to, as I say, to the relevant colleagues, because we understand it's a very sort of saturated space. So again, I really do apologise for being slightly late, and apologies that's just a little bit of a run through. But I know Hannah has a fantastic presentation on the sort of Muse and Newt work, so I'll hand over to there, and very happy to answer any questions that anyone's got in the chat, and I'll put my email in for anyone else. So thank you.
Thank you, Charlie. And can I have the next slide, please? So thank you ever so much for inviting me along today to share sort of like an update really on the deterioration work stream. I'm sure it's been quite a while since any of you have heard of the progress that's been going on behind the scenes regarding the Muse and the Newt tools. So it's a pleasure to come and just give you a really quite brief update of what has been a long 18 months of really trying hard to get the right tool together ahead of testing. So if I could have the next slide, please. And the next slide. So I'm going to start in the neonatal space, if that's okay with everybody, because actually we are live and testing with that currently. But we have achieved so much in the 18 months since we started the work with our BAPM colleagues, and in 2020 we were approached by BAPM to support them with their refresh of the current Newt tool that's out there at the moment. And it was due for revision, and there was some issues in following 2015 version of really successful adoption and spread of both the Newt tool and the framework. So we, Tony and I, went along to support the refresh of that, and to really help progress the work on behalf of the BAPM core design group. It's been a really, really interesting journey with our BAPM colleagues, and really it's been quite an exciting journey to take a group of colleagues along a more improvement approach to the whole concept of refreshing a tool, and actually that things need to be tested along the way. So it's been a really good experience with them. And currently we are within 14 organisations in the country going through some usability testing on behalf of BAPM to actually get some feedback on the language and the layout of the new refreshed tool, because there's been some additions based on NICE guidance and also just based on some themes from sort of incidents running up to the refresh of it. So we have currently started that. We are commencing that at pace. We will be presenting back to the BAPM design group at the end of April, because this testing phase has gone alongside their consultation for the framework, and we're hoping that we will have publication of that new tool sort of end of April, beginning of May, to start thinking about adoption spread in the summer months of that. If we could move into the next slide, please. And just moving into the Muse space, so there's probably quite a lot of information to disseminate to you here, but I'm not sure of actually how much information you've had prior to this regarding the journey, because it's been quite a long one. But actually in 2020 we brought together a group of key stakeholders, and by key stakeholders I'm talking academics, RCM partners, RCOG partners, Chief Midwifery Office, anaesthetic partners, also ambulance service involvement, so that when we actually came to having the finalised tool, we knew that there had been a really good array of stakeholders involved at every opportunity of that key design phase. For the physiology, for the 6 physiological parameters used within the new Muse tool, we have actually based that on some data and the 4P data set, which was actually brought together by Peter Watkinson and his group at Oxford. So really good evidence base behind the physiological parameters that have been set for the Muse tool. And during the period of time from beginning to now, we've gone through quite a number of consensus building exercises. So how we incorporate additional concerns, i.e. healthcare professional concern and women and families concerns, and also the thresholds and triggers, so who you escalate to, the response mechanisms, and actually what the escalation process would be if your primary person was unable to come along and help at that point in time. And we've also done some prototyping along the way of how this tool should be laid out, and used many clinicians across the country to really inform the design and layout of how the Muse will look moving forward. If I could have the next slide, please. So there's at one point during the Muse journey so far, we had an agreed tool from 18 weeks of pregnancy until 2 days postnatal. And actually at one point we were really quite worried that we were going to end up with 3 separate tools. So a tool for, when I say tool, I mean chart. But we thought that we'd end up with 3. So one for pre-18 weeks, one for 18 weeks to 2 days postnatal, and then one from 2 days postnatal to 4 weeks. But from further modelling of the data, it actually became quite apparent that actually with a small tweak in the postnatal continuum, so from 48 hours post-birth, where actually the area of concern was predominantly around the pulse rate, we have actually been able to incorporate that. So we now have one tool that we're ready to go out to testing with from conception right through until 4 weeks postnatally, which feels like and is a huge achievement to have that one tool. Could I have the next slide, please? Just moving into the digital world, because actually what came as quite a shock, if I'm really honest, is actually how challenging it is to move a Muse paper-based tool into a digital world. There are some massive advantages to being digital, as you can see here. Actually, the parameters for 2 days postnatal would automatically change, so we wouldn't actually have to have any thought process behind that. But I'm also here to reassure you that actually we're working really closely with our NHSX colleagues currently, and developing a national specification for the maternity early warning score. And sorry, an email just whizzed in, it caught my eye. so working along with the NHSX colleagues to develop a national specification so that actually we can go to the digital providers and have those sort of in-depth conversations about how we can get Muse onto their digital platforms without that impacting greatly on organisations. The one thing about a national specification is that we are really excited about the prospect of working alongside all of the early warning score personnel and actually having potential for tools looking similar in whichever areas that you go to. So for junior doctors moving around patches for their training, etc., actually having early warning scores that are looking similar, so there's no sort of unintended consequences of having lots and lots of different tools around the system. Could I have the next page, please? And just moving into the plans for testing and adoption and spread of the Muse tool. So we're really excited. Our tool is currently with our design group awaiting sign off. And then we'll be ready to launch into our phase 1 of testing. So we're planning our testing for the Muse tool in 2 phases. Phase 1 will be very much cold case review for usability testing, so feedback on language, colours, layout, etc. And phase 2 will be more of a live testing environment, so current tool within organisation alongside the Muse tool. I appreciate there's probably some governance issues that we need to actually address and work out from the national team before we progress with phase 2, but we're very much excited to be sharing with you that we are ready to move into the phase 1 of testing after Easter, which will be very exciting. And then with early adoption and spread to those early implementer sites, I say June and July there, quite possibly more towards sort of July, August, September, in all fairness. Could I have the next slide, please? I just wanted to touch on the peer framework with you. If I could just have the next slide, please. And just being really mindful that Muse itself is a chart, is a tool that is actually sits very well into the eye of the peer framework. But actually to support the Muse tool, we actually need to be thinking about prevention and risk assessment, but also about the escalation and response, and actually what tangible implementation ideas we can have to support escalation and response that is heavily embedded within the Muse tool. There'll be more information coming with that, and obviously with the release of Ockenden in the last week, how we can align our thinking with escalation tools moving forward. But this is just to serve as a reminder that the Muse tool is the identification. Actually, there is a whole pathway around that regarding escalation and how the response to that escalation is managed in organisations. Could I please have the next slide? I'm really mindful that lots and lots of questions have come into the chat. I will endeavour to answer all of those when I finish the presentation, but my email address is on the end of this presentation. If you wanted to pick my brains about anything one-to-one, that's absolutely fine. And Gemma, I'm more than happy for these slides to be shared more widely after this presentation. And just moving into the next steps in the deterioration work stream, we have been really mindful, both Tony and I have a maternity background, I'm a midwife by trade, and Tony is obviously still working clinically also. We are very mindful of what the capacity has been like within systems during the pandemic, and have really adapted our testing plans with that in mind moving forward, but also being mindful that we can't put a tool out into the system without actually testing it either. There has been and still is appetite for this work moving forward, both at PSC and trust level. We are aware and really mindful that some organisations across England have put off transferring to a new maternity early warning score, waiting for the national Muse score to come out. So we're also mindful of that as well. So we're mindful of capacity, but we also know that people have been waiting for this for a little bit of time now. So we feel that our scale up is realistic within the current pressures, but also we're quite mindful of other systems and work and priorities for the MTP and the Chief Midwifery Office, and also at the moment just picking through and really taking on board the recommendations from the second Ockenden report last week, and actually trying to systematically work through how we can support the recommendations that have come out from that report. Next slide, please. So those are all our contact details. I appreciate that was a lot of information in a very short space of time, and I really honestly do not mind any further emails coming through to me if you have any further questions, and I will go back to the chat and answer as much as I can in there as well. Thank you for listening to that.
Thank you, Hannah and Charlie. Such a fantastic piece of work, and I regularly sit on the Embrace panels, and I think to have a national tool that's standardised for both news and Muse is really welcome. So I'm really excited to see that work going forward. There's just there's loads of I mean, everybody's saying the same thing in the chat. There's a couple of comments around Muse digital suppliers have Muse charts on their systems. Do you know if the suppliers are testing these? I'm not quite sure. I mean, I'm not familiar. Yeah.
No, we have a plan. So we are having to initially test in paper-based organisations. We just know that we need to get it right on paper before we move into the digital world. We also have a couple of providers that are willing to test this for us in the digital world. So Badgernet is really keen to help us test, and also so is Cerner. So we are trying to think through all of the complexities of digitalizing both the Muse and the neonatal. So it is very high on our agenda to and we're hoping that NHSX then will support us with those engagement activities with digital providers to digitalise the Muse. There was a lot of digitalisation in that sentence, sorry.
That's fantastic, Hannah. So much work going on in that. I'm going to move us on because I'm not doing very well at time, keeping an eye on the time. In typical sort of IT fashion, Olivia's had a power cut. She was supposed to go next, so we're just going to put her at the end of the agenda and just move forward to optimization, delayed cord clamping. I don't know if Devangi's managed to. Yep, here she is. Thank you. I'll hand over to you. Thanks for coming in early.
No problem. Thank you so much for having us. I'm actually going to hand over in a second to Jamie Shah, who's one of the registrars based at Hillingdon, who's going to present the work that we've been doing for just over a year now. And before he starts, I'd just like to say a really, really huge thank you to everybody at Hillingdon, because this obviously isn't something that Jamie and I have done alone. It's a whole lot of people behind the data we're about to present. So thank you, and I'll hand over to Jamie.
Hi, everyone. Can you guys all hear me?
Yes, we can. Yeah.
Perfect. So I just wanted to echo what Dr. Taka has said, that this is a massive project, you know, and I just wanted to say a big thank you to everyone at Hillingdon Hospital from the Women's and Children's Services. So my name's Jamie. I'm one of the paediatric registrars with a keen interest in neonates. And Dr. Taka is our consultant paediatrician with a specialist interest in neonates. So just wanted to talk a bit about our normothermia and optimal cord clamping project. So a little bit about what I'll talk about. So just the definitions of normothermia, a bit about delayed cord clamping, our NNAP data, so National Neonatal Audit Program data for the year of 2020 at Hillingdon, and a little bit about our QI projects, the results, and learning points that I think we can share across the board and across the network. So what is normothermia?
Slides moving. I can't actually see the slides moving. Yeah, Jamie, just ask for your slides to move when you're ready.
Sorry, yes, sorry. Yeah. So next slide, please. So normothermia is defined as a temperature between 36.5 and 37.5. And what we found from work in 2015 is actually that having a temperature outside of this particular hypothermia is strongly associated with mortality and morbidity at all gestations, but more so in those of preterm, particularly under 32 weeks gestation. And there's also emerging data that suggests a similar adverse association between hypothermia with temperatures above 38 degrees. Next slide, please. So looking at delayed cord clamping, So in 7 recent trials looking at just over 2,800 babies, we've actually found that avoiding immediate cord clamping and doing delayed cord clamping has shown a reduction in mortality by almost 1/3. So it is quite a significant amount, which is why we feel it has quite a bit of an importance. Next slide, please. So currently, delayed cord clamping is recommended by NICE. There's very, very few situations where delayed cord clamping is not recommended. And there's only 2 situations that NICE states where they wouldn't recommend it. The first one is any concerns of the cord integrity. For example, if it had been snapped, damage, bleeding, or if there's concerns regarding the baby's heartbeat. So if the baby has a heartbeat below 60, that's not getting any better. Next slide, please. So this is our national neonatal audit program data from Hillingdon. And the black diamond that you see is our network, so Northwest London, and the blue dot is Hillingdon. So what you can see is actually we are performing better than the network average in all areas. But one area that we particularly wanted to highlight, which we're doing very well in, is our follow-up at 2 years, which you can see as the second from the bottom. Next slide, please. However, one of the areas where we are lacking in comparison to our network is temperature monitoring, and this is of our admission temperatures for babies born at less than 32 weeks. So less than 32 weeks with a normothermic temperature. The network average was 72.3%, whereas we were below that network average at 64.3%. New slide, please. So this plot just shows kind of the rate of delayed cord clamping across the UK and across different networks, as delayed cord clamping only became a NNAP measure since 2020. And what we can see looking at this slide is actually the area that we're in, so London Northwest, has an average of 23% delayed cord clamping, whereas the rate across England and Wales is actually 28.9%. So as a network, we are slightly below the rate. Next slide, please. So in terms of our delayed cord clamping, we looked at the data previously and found that actually 30% of our babies born had delayed cord clamping. This is looking specifically at those babies born at 32 weeks or less gestation. But what we also found that in 21% of cases, we didn't know if children had delayed cord clamping or not. And in 27%, there was no delayed cord clamping, and the reason for not doing delayed cord clamping was unknown. Next slide, please. So what we wanted to do particularly to kind of improve that is get all of the stakeholders involved in delayed cord clamping. So stakeholders range from junior trainees, both in the neonatal and obstetric and gynae departments, practice educators, our neonatal nurses, our consultants, both obstetric and neonatal, theatre staff and midwifery staff, and really involve and engage our stakeholders. Next slide, please. So we used the BAPM toolkit, which is shown as this slide, to kind of focus on both our normothermia. So this is a normothermia toolkit from BAPM. Next slide, please. And also the BAPM toolkit for optimal cord management as well. And we did a lot of work, of group work, to really help us kind of focus on the cord issues and the real crux of the issue. So things that we did, including lots of mapping of patient journeys, a lot of education working with different groups separately. We actually added on delayed cord clamping onto the preterm checklist. We added in multiple simulation videos. And one of the things that we did as well is we added our Neo help bags, which are actually plastic bags, which are sterile. So, and they come with a hood as well. So that delayed cord clamping can be done much easier and more comfortably in those babies less than 32 weeks. We also did a lot more focused training, managing to aim for normothermia. And we're currently in the process of creating information posters. And we found that actually this information sharing within teams, small talk on WhatsApp group, newsletters as well, regular cycles of auditing and re-educating and involving the right stakeholders at the right time has been crucial. And that's why we've been able to make multiple changes, which I'd like to highlight next. Next slide, please. So this is our admission temperature. So what we've noticed is we're actually normothermic now on 86% of all our preterm admissions less than 32 weeks, sorry, whereas previously we were at 64%. So that's actually quite a significant improvement. And in regards to our delayed cord clamping, next slide, please. We've noticed that actually we've improved from 30% to 50%. And also there are no unknown cases of if delayed cord clamping was or wasn't done. And we've reduced the rate of no cord clamping done for an unknown cause from 27% to 15%. So actually we've made quite a significant improvement. Next slide, please. So finally, this is where we are in our current journey. So we're just in the kind of stage 5 of our audit cycle about just implementing widely our learning. We've defined the problem, developed and shared our purpose, planned and implemented changes and tested measures which have worked. And now we're just kind of continually improving and re-implementing those measures and making sure that we sustain what we've done so far. So next slide, please. So in terms of our learning so far, teamwork is really, really important. It's really important engaging the right people. Engagement can be via many, many different ways: WhatsApp, simulation, newsletters, meetings, teaching sessions, and again, similar ways to communicate about it, talking about it often in as many different ways as possible. And the other thing as well that we've constantly done here at Hillingdon is really celebrate the wins. This can be in forms of great X's, direct feedback, and just really, really keeping up that momentum and continuous motivation. And we found that's made a huge difference as well. Thank you for listening. Be happy to take any questions at all.
Thanks so much for presenting, Jamie. Presented that really well. Really happy for any questions, and thank you again to the Hillingdon team.
Thank you. I just wanted to say again, and there's loads of comments in the chat, everybody's so impressed. And I think, you know, your data is really impressive, and especially to see the variation, you know, across the sector. It tells us that actually we can make improvements. And I think, you know, you sharing how your improvement journey on how you've done that is fantastic. And we know that, you know, we know the benefits for neonates. So everybody we need to get on board. So thank you so much for sharing that. I don't know if there's any other questions that anyone's got, but we can make sure if anyone's got any questions, we can make sure that everybody's email is available at the end if you want to directly email anybody. So thank you. Just moving on to the agenda now, if there are no questions popping up, we're coming on to Nisha, which is again optimization, and this is development and delivery of the preterm birth training package across Northwest London. Hi, Nisha.
Hi there. Thanks for having me here, everyone. So my name is Nisha. I'm one of the consultant obstetricians, just leading this preterm birth training package that we've been running for about a year now, just over a year now. I've got some slides. Here we go. Perfect. So I'm just going to talk a little bit about what we've been trying to do, essentially. Next slide, please. So this project was initially funded by Health Education England and created by the North West London LMS. Next slide, please. And the premise is to try and create or support and encourage a consistent approach to preterm birth management. And the aim was to try and support elements of Saving Babies version 2 and the MatNeoSIP. Next slide, please. The purpose of the package is educational, primarily, to increase awareness of prematurity and management strategies, to start thinking about referral pathways at individual trusts, and what's actually available at the moment and where things can be improved. And then we also talked a little bit about prevention tools in this training package. Next slide, please. So the sessions are publicised across Northwest London. Participants would register with Eventbrite. They have a pre-training questionnaire trying to assess their knowledge base to begin with before attending. And the idea is to try and also behind the scenes also determine the kind of existing preterm birth services, the use of other tools such as fetal fibronectin, and then also this piece of work to try and evaluate in utero transfer management, and that's sort of London-wide, I suppose. Next slide, please. Our main outcome measure is to just assess the staff knowledge and whether it's improved by attending a session. So, as I said, it's all very educational. Next slide, please. So we are a multidisciplinary team, and we have representation across Northwest London and the LMS, and the package is developed and is delivered by midwives and doctors across the LMS. It's educational. We try and make it practical, so with lots of case-based discussion. We invite questions, and it's also interactive. You just hold on a second. Sorry, I'm just away and my family's just interrupting. Yeah, so it's multidisciplinary with good representation from everyone. Next slide, please. So we run it as a half-day session. We've tried running it in separate sessions and running it as a whole. It generally lasts about 3.5 hours to 4 hours, including breaks. We have 20 to 30-minute talks covering prediction, prevention, and preparation aspects of preterm birth care. Each session after a talk has an interactive element with case-based discussion and short quizzes to try and encourage participation. And next slide, please. And post-training, we kind of want participants to think about and evaluate the care they provide at each trust, looking at ways they can improve it. And we give examples about how we would see preterm birth care run in a practical sense with case discussion. And we want participants to think about what exists in their individual trusts, what tools are available and how they use them, and also start thinking about in utero management to try and maximize the number of in utero transfers, particularly to tertiary centres in Northwest London. Next slide, please. So we've been running for about a year now. Initially, the plan and the funding included back-paying staff to attend in face-to-face sessions, but that obviously was changed very much by the pandemic, and we had to evaluate and change. So this is primarily run as a webinar now. We run them quarterly. They're publicised across Northwest London, and we get really good cross-network participation from all NHS trusts, and we've been quite proud of what we've achieved so far. Next slide, please. So this is just an overview of the general participants. We get participants from consultants down to students, including support workers, SHOs, midwives. The vast majority are midwives, and the aim is to try and target frontline staff primarily, particularly those working in triage units and antenatal care. Next slide, please. And we do ask our participants with their questionnaire beforehand to try and figure out what their knowledge base is to begin with and how much they think about the different facets of preterm birth. And as you can see, generally, our participants are familiar, and they will often be looking after patients who come in either with acute symptoms or in the antenatal period, patients with risk factors for preterm birth. So our aim is to try and target those individuals in particular. Next slide, please. So we're trying to establish what their baseline is in terms of the confidence of managing cases of preterm birth and how we can improve that and whether our training package meets that aim. And you can see from here, in general, confidence with managing preterm birth and their knowledge base with regards to preterm birth is improved by attending the package. And we have questionnaires before and after the course to try and establish that. It's a fairly significant change, particularly those who are somewhat or not very confident, becoming far more confident or extremely confident. And it's the same as in terms of familiarity with managing preterm birth. Next slide, please. We also want participants to start thinking about risk factors associated with preterm birth, particularly those that are modifiable and non-modifiable, and trying to understand how that plays into preconception role and in early pregnancy. And again, as you can see, there's quite significant improvement, particularly in terms of knowledge base. And then our post-course question also asks about how we can improve the package itself. And in general, the feedback has been that it's been, from an education point of view, very, very useful. And the next slide, please. And lastly, we do ask about general comments in terms of the package, and most participants feel like it's informative, is well structured. They do like the interactive elements, and are keen to encourage their colleagues to attend as well. I think that's it. Last slide. Is there anything else?
Thanks, Nishal.
Posted for the session for anyone who wants to attend.
Perfect. I will definitely be attending that, and I think so. Firstly, just thank you for joining when you're on holiday. So I know everybody on the call will appreciate that. So thank you, and great event, everybody. I'll let you just take a note of that. And I know there was a couple of, and everyone's saying the same thing. They'd really be interested in seeing the preterm training package. So we'll all be able to join in on the 8th and look at that a bit further. There's just a couple of other questions coming through. What's the uptake of the Quip app? How's that going with you guys?
Well, locally we use it quite frequently, but we do talk about the Quip app in particular during this training package, trying to encourage people to start doing, offering ambulatory cervical length assessment, or at least try and find a way of facilitating that using the fetal fibronectin and then using the Quip app. We do encourage it. I think it's a very, very useful tool.
Fantastic. And I think we've got your presentation links in really nicely actually with the panel discussion from a midwife called Zoe Manton, who's coming on a bit later. I don't know if you, I know you're on holiday, Nishal, if you can hang on another sort of 20 minutes in the background. She's talking about midwives doing preterm birth assessments. And I just wondered if your midwives do that where you work, or if anybody else on the call, if any other midwives do preterm birth assessments.
I think there are lots of other trusts. In Chelsea and Westminster, we don't have. We have research midwives associated with the preterm birth clinics, but we don't have midwives doing cervical lengths or doing fetal fibronectins. But other trusts, I do gather, do have that facility, and it would be really nice to encourage more. I mean, we're very happy to have midwives doing these sorts of things.
Yeah, fantastic. There's another question just You're getting lots of questions, so which is great.
Don't have neonatal info, actually. That's something that is missing. We talk about the neonate, particularly with preparation, which is the last bit of training, because obviously the 50% of spontaneous preterm births you can't predict, and they'll go on and give birth preterm. We don't have neonatal input. We could have that. Useful.
Nisha, did you say, are you a level 2 or 3 unit? Did you say?
Level 3.
Level 3. Okay.
Yeah.
I mean, I think this would be great. I mean, I'm working in a level 2 unit, and I don't know what everybody else is thinking. I think, you know, these sort of packages really help if you're getting that identification right, you're getting the history right, especially to help with transfer as well. And I know sometimes from transferring from level 2 to level 3 units, obviously, sometimes there can be time delays, and then the women deliver and they've not delivered in the right place. So I think it's really exciting what you're doing, and everybody, if you can, we'll get that sent out as well for those of you that are, I know a few people are on the move, but we'll get this.
If anyone wants to ask any other questions.
Perfect. One more question has come through for you. Can I ask, will you be willing to share the content of your training? I.e., is this training about cycle assessment, steroids, antibiotics, and magsulf?
So I would be happy to, because I'm trying to set it up so that we can run it, we have recorded talks and run them, and then we can have different people facilitating, particularly for the interactive stuff. I'd be happy to, because it's very easy to shift that to a London-wide package if anyone wants to just, any other trust want to join. I mean, I think that was always the intention anyway, eventually, to try and have this running in more than just Northwest London.
I mean, that's great, isn't it? And that's exactly what we wanted this Pan London event to be sharing our training packages, ideas, and quality improvement. So so thank you, Nichelle. You're getting the most amount of questions. Do you include advice given to ambulances about the priority of transfer? It's a good question.
We don't talk about that. So I think that I'm joining the Pan London working group from an education point of view. It would be really useful, because in utero transfer is a big subject matter in London, to try and work with that so we can give the right information to trust. That would be really helpful.
Thank you, Nichelle. I'll save you from any more questions, so you can go back to enjoying your holiday. But I'm just going to move us on, just because we're getting tight on time, and I think we'll probably be here asking you lots of questions all afternoon. So thank you for such an interesting presentation. I'm just going to move us on now to Rosie Murphy. Thank you. Who's going to talk about health inequalities with a particular focus on perinatal. Thank you, Rosie.
You're welcome. Thank you so much for inviting me here to talk this afternoon. I'll just wait for my slides to appear. Also, while I'm waiting, it's worth saying that I submitted these slides last week, which was both before the publication of the most recent Ockenden and before we hosted our event, which I will come on to talk about. So it now feels like they're about a year out of date. So I apologise if it seems a bit clunky. By way of introduction, I'm Rosie Murphy. My background is midwifery, and I'm doing this project as part of my Darzi Fellowship at Croydon. I don't think we've got time for me to talk much about the Darzi Fellowship, but I will put my email address in the chat if anybody wants to ask me anything about the Darzi Fellowship programme, because I highly recommend it, and I'm really grateful to Croydon for hosting Darzi Fellows, because it's been an excellent experience so far. Next slide, please. Okay, so the focus of my Darzi Fellowship is on perinatal equity for Black, Asian and minority ethnic women in Croydon. And as I'm sure you're probably all familiar now, there is a significant disparity in terms of perinatal mortality and morbidity for women and birthing people from Black, Asian or mixed ethnic backgrounds when compared to white British women. So the most recent Embrace report in November 21 demonstrated that Black women are 4 times more likely to die during pregnancy and the perinatal period, and Asian women twice as likely to die. There's also good evidence to demonstrate that the Black, Asian and women from mixed ethnicity backgrounds are also disproportionately likely to lose their baby during pregnancy or soon after and suffer other adverse outcomes such as prematurity or fetal growth restriction. And there is evidence to suggest that this disparity can be partially explained by poverty and comorbidities. And I think, at least to start with, there's a real will to think that this is the entirety of the picture, but actually there's a growing body of evidence to demonstrate that structural racism is another factor that is both independent of and intersecting with these. Next slide, please. So what continues to emerge from a number of reports is the theme of access to maternity care, and inadequate access to maternity care is associated with poorer outcome. This is quite well documented in the Embrace reports under their various acronym titles for the last decade or so. And I believe in the most recent report, there was 19% of the women who died, their care was rated as inadequate in terms of the access that they had to care in the most recent Embrace report. What we know about access is there's a little bit of literature on late booking, and late booking is quite strongly associated with non-white ethnicity, being from a non-English speaking background and birthplace other than the UK, which stands to reason that that's something along the lines of how do women understand how maternity services work and how they get their foot in the door and when. But it's also worthy of note that for women who do speak English and were born in the UK, Black Caribbean ethnicity is still strongly associated with late booking. And on a local level, there's good data to suggest that this is the case in Croydon, that care is not accessed in an equitable fashion, both in the sense of the original referral into or self-referral into maternity services, but also more anecdotally an emerging picture of there being quite a disparity in terms of the point at which women will access care more acutely. So that is both in the sense of the point at which women will first present to maternity services when they're concerned, but also I think it's important to point out that particularly what's just been identified again in Ockenden and a couple of other things I'll come on to talk to is that there's the intersection of appearing to present late is actually also possibly explained by Black and Asian women having had a lifetime of not having their concerns taken seriously when presenting to healthcare. Next slide, please. And as we'll all know, as I mentioned, this feels very old now, but since, again, the publication last week of the second Ockenden report, the theme of listening to women has emerged repeatedly through multiple sources, continues to emerge, will continue to emerge. And I think it's important to note that that happens obviously on a general level throughout maternity services, but there's, as well as healthcare in general, it also came up in the first Do No Harm report from Baroness Cumberledge. But there's also emerging evidence yet to be published. So the charity Birthrights of this year, last year, conducted their inquiry into racial injustice, which is due to be published soon, but also 5 times more in their collaboration with the RCOG. Their #1 recommendation was listen to women. And Birthrights have definitely identified, even though it's not been published yet, I've spoken to people who've taken part in that women not being listened to in the sense of not having their concerns taken seriously comes up disproportionately for women from Black and Asian backgrounds. And I think it's important to consider whether the structures that we use in maternity to listen to women, and I'm now moving on from the listening to the woman presenting in front of you in a clinical capacity to the more overarching theme of feedback into the maternity system. Do the structures that we use in maternity really facilitate hearing from the voices from whom we need to hear the most? So do the MBPs represent the populations that your maternity units serve? Next slide, please. So the aims of the project are really to create a more robust network or system where information could be more readily disseminated into the community. So via community leaders, faith groups and the voluntary sector, but also for that network to support the exchange of information in the other direction as well, recognising that it is often the case that maternity voice, the participation of maternity voices partnerships isn't truly representative of the population that you serve as a maternity service. So to be able to support more reactive and responsive service design through feedback from the community alongside the MVP as well, and perhaps considering whether we can reconsider sort of the shape and the structure of the MVP and moving it something more towards co-production. Next slide, please. So the key deliverables or the outputs of the project is number one, a Whose Shoes event, which we hosted on Monday this week. And I'm pleased to report it actually went really well. The participation was much bigger than I expected. We had to get another table, we had to get another board game out because so many more people came than we were expecting. We took a slightly different approach to inviting and hosting the event in recognition of what has come up through the scoping work, which is one of the barriers being mistrust or distrust of the health service, particularly in the communities that we're seeking to improve outcomes for. So instead of just putting a poster up within maternity services, I've spent quite a lot of time building relationships with and collaborating with a number of community organisations, which we're so fortunate to have in Croydon. Really well developed organisations, and we both hosted the event at one of their venues. It sent out almost all of the communications and media about inviting people, and also were very kind and supported us with other things like refreshments. Because it was felt that if we put just a poster up in maternity, that we would probably inadvertently be engaging the same women that we seem to be able to engage quite well that come along and do sit on our Maternity Voices partnership. And the people that we invited to come were pregnant women, their partners and other family members from Black and Asian backgrounds who've had a baby in Croydon, and were specifically quite vague about when they had to have a baby, because we recognise that a lot of these issues are not new issues. Next slide, please. And so then the overarching aim, the Whose Shoes event was just sort of the launch pad for this work, really, to engage members of the community and community organisations into establishing a multidisciplinary, multi-agency and citizen or service user co-production forum, specifically with a focus on disseminating information into the community better to improve timely access to perinatal care for Black, Asian and minority ethnic women. And again, testing out where we can really move and bend the shape of the Maternity Voices partnership to make it more inclusive. So testing out whether we can have people who obviously come along and sit on the Maternity Voices partnership, and that's wonderful, but whether we can have sort of a next degree of structure as well, which is to have people that we engage with for particular projects, and also to invite these community organisations that are so well embedded into the communities of Croydon to come and take part in the work of our Maternity Voices partnership in recognition of the connections that they already have with the community, and to be able to build that bridge of trust where there currently is mistrust. Next slide, please. So the barriers, as I've already mentioned, what's really been reflected back at me in the scoping phase of this work is the lack of trust of institutions, in particular the NHS, and it would seem maternity service within that, from the communities that we seek to engage with, that is a huge barrier to women wanting to come along and share their experiences of their maternity care. A lot of trauma within the community from women, from their experiences of giving birth, and an unwillingness to engage because they don't feel that their concerns will be listened to and acted on. One of the other barriers with this work is that so much of it is about relationship. I've invested a lot of time building relationships with these community organisations, and that takes a lot of time both to build and to maintain. And that challenge is sort of reinforced by the slightly questionable suitability of doing this work within such a short-term project, because the more I do, the more I realise that this is years and years and years of work, and we have to start somewhere. But the possibility of people seeing me come for 12 months and then leave again runs the risk of reinforcing that mistrust, that this is a tick box exercise for the trust rather than out of genuine concern and wanting to make a change. One of the other barriers, both to attendance at the workshop as well as engagement more generally, is financial barriers. So reasons cited for not being able to attend are not being able to afford transport, lack of childcare, not being able to either take time off work to be able to attend these events, or not being understandably quite willing to use up their paid holiday, which is quite understandable, and again speaks to how we need to reconsider what we can offer people who want to take part in the Maternity Voices Partnership, because it's perhaps slightly outdated for us in the NHS to be thinking that people are always just going to be able to come along and give their time for free. And one of the other challenges is in this area is the secondary mental health services are commissioned by another trust, and they're doing a lot of work with a lot of the communities that I'm trying to engage under the PCREF, the Patient Care Race Evaluation Framework. And the patient engagement work is remunerated in some level. Some of that's vouchers, but generally speaking, it's a huge overarching project for the whole trust, and they've got all of these groups in various different localities, but that's what I feel that we're up against here, is that people are already engaging to do work with the NHS, and I'm a little bit standing in their shadows asking them to do it for free. Next slide, please. So next steps, in recognition of the fact that I've had a level of enthusiasm demonstrated even from women who felt that they weren't able to attend the Whose Shoes event, is to take out and go on a series of Whose Shoes roadshows. So just take one copy of the board game, go and play it with 5 or 6 women in a location that's accessible to them, in an environment where they feel able to speak. That was definitely reflected back to me as well, is concern about speaking up about their experiences in a big room, but that perhaps that it would be more palatable to do it in a small group, to continue to build relationships and seek out more stakeholders with whom to engage in the local area. And certainly that's emerged from the event on Monday. We did have good representation from other voluntary organisations representing women and young families. And to continue with those stakeholder interviews with those new stakeholders to explore further in light of what's been identified in terms of barriers to engagement, but also engagement with antenatal care, what women know about the MVP, what they think about the MVP, what reasons why they might join, why they mightn't join even if they did know about it, and to continue that strand of work looking into whether we can reshape, remodel the nature of the MVP to make it more attractive to people to want to participate. And then an idea that has emerged and again came up at our event on Monday is the development of maternity champions. I have been since made aware that there is already work of this nature going on, I think somewhere in northwest London, about having some local community champions for maternity care. And somebody suggested the possibility of training hairdressers to just have conversations about when to refer into maternity services, both initially, but also about when you should be concerned, when you should be contacting maternity services during pregnancy, because lots of women either go to the hairdressers quite often or sometimes go and spend quite a lot of time at the hairdressers, and being able to just have those conversations more organically, even perhaps with women who aren't yet pregnant, to just try and spread that knowledge into the community, I think has the potential to really make a difference. And then the ultimate outcome from the project is to co-produce with these stakeholders and as many service users as I can engage for recommendations for Croydon Maternity Services about how they can keep this work going, and how to make change in this area, including planning the impact evaluation, because I think that's quite important to engage the community with how we measure our progress in this line of work. And I think that's it. Is there another slide, Gemma? No, that's it. So I'm very conscious that we're short of time. I'll put my email address in the chat and answer any questions that have popped up in there, or please get in touch because I don't want to take up any more time.
Thank you so much, Rosie. That was a fantastic presentation. I wrote down so many notes when you were talking and interested. I mean, I really like the idea of community hairdresser, and my hairdresser always gives life advice every time I go. So I was just thinking, if you spoke to her, she'd be a good person. And Jane Sandel has put in the chat that she's doing a research program at the moment, engaging with hairdressers and barbers in South London regarding long-term morbidities, and she's happy to touch base with you about that. So I think that's a really interesting piece of work, and I'd love to invite you. I mean, this is our first Pan London event that we're having, but I would love to invite you back, that once you have co-produced your recommendations, I think that all of us could utilise those recommendations for the work you've done. I think it's absolutely fantastic. And yeah, we need to think about how we get a wider audience in the MVPs. And that's definitely something that we're working on. So thank you so much for all your work. And everybody's just, again, saying thank you.
Thank you so much for having me.
Welcome. We'll invite you back again to see the recommendations.
Yeah, I'll be very happy to do that. Thank you.
Thanks, Rosie. So moving on to the agenda, we're going to move over to our panel discussion now. And this is with Zoe Manton, who's a midwife from Lewisham and Greenwich, and Sabina Das, who's a consultant obstetrician at Imperial. And this is a panel discussion about how we can address the challenges of improvement within a, the difficulties we're having with staffing at the moment. So I can see, yep, Zoe and Sabina have just joined. So I guess both of you are doing lots of really good improvement work. So I'm just interested to hear what you're doing and how you keep the momentum. We know that we've got, these are exceptionally challenging times, and I think everybody on the call will be feeling that. So I'll hand over to Sabina and Zoe just so we can hear a bit about what your improvement projects are. And please, anybody wants to jump in and talk about their projects as well, just put your hands up. Really welcome to join.
Hi, Sophie. First of all, it's Sabrina. Sorry, not Sabina.
Apologies.
It's okay. I thought maybe we could do this in a fishbowl kind of structure. So I was wondering if people could turn their cameras off, except for myself and Sophie, and who was our other panel member?
I'm Zoe.
Zoe, here you are. I can see you now. Yeah, so that if everybody else turns their camera off, so it kind of feels like the three of us are having a conversation. And then I think you can change your Zoom view so that only the people who are who have the cameras on you can see, and then we can take it from there. Because I'd kind of like to pretend almost like we're having a conversation for maybe about 5 or 10 minutes, and then people can turn their cameras on and kind of jump into the fishbowl. How does that sound? As
fantastic.
as a structure for this panel. Good. So I can't see Zoe. Zoe, where is your camera's on, isn't it? Sorry.
He's on, yeah.
There we go. Okay, it's just a kind of a setting thing on the Zoom. Yeah. So maybe do you want to start us off? Because you were telling us about some work that you've been doing, Zoe, when we were chatting before. Do you want to maybe tell us again?
So I'm the triage lead here at Queen Elizabeth Hospital, part of Lewisham and Greenwich. Been there for about 8 years, and about 18 months ago or so, we had a preterm teaching, and it kind of highlighted there and then about the fetal fibronectin and actin proms and preterm assessments that we do for ladies. And it kind of got me thinking about the long waits that our women experience when they come into triage, threatened preterm labour, queried preterm SHROM, abdominal pain, PV bleeding, trauma. They would sometimes sit, 2 or 3 hours waiting for a junior doctor to come along, do a speculum, do the tests that were necessary, and make a plan for them. And it was really, thinking about it, it was really like anxiety provoking for the women, the long waits, not knowing what was happening. And it was quite anxiety provoking for the midwives sitting in triage, not knowing if we were dealing with a lady that was, potentially having a miscarriage or, threatened preterm labour. And we realised that, we were wasting vital time with these women sitting in triage for hours, when they could be potentially on delivery suite, having the care that they need, having steroids, having Magsolve, having tocolytics, while, in case they were in preterm labour. So we sort of looked at maybe midwives, the triage team, taking over that part of the assessment. I met with our clinical governance midwife, put it forward, who was all for the idea, but had a completely different idea of who we should be examining and who we shouldn't. Then I spoke to the labour ward consultant lead, who had completely different ideas and was like, it's absolutely fine if you're going to speculum one person, you know, there's no reason why you shouldn't do everybody that comes through the door. So I wrote an SOP, it went off, it was looked at, and in April 2001, the midwives that were working in triage took over that part of the assessment for the ladies that present to triage.
2021 or
yeah,
2001?
So we've been doing it for a year now.
All right, you said 2001, so that's like, you have been doing it 22 years.
No,
yeah.
we've been doing it for a year
Okay.
now. We've been doing it for a year, and it's an absolute game changer. It's so much better. So much better.
So you make it sound like it's been really easy to do, but
really
what I found
easy.
in reality with these things and a lot of kind of QI initiatives, that is more about the culture change, whether it's something like delayed cord clamping that we've known that's beneficial for a long time. So how did you find that culture change, shifting? Did you have any barriers?
It was taken on board relatively easily, actually. And we are a small team of triage midwives. There's just 7 of us. So we decided from the offset that it would just be us 7. So if unfortunately one of us wasn't working in triage and it was another midwife, it wasn't them that were going to do it. They could still call the doctors to do it. As time's gone by, you know, triage is usually covered by very senior midwives. It's not usually your junior midwives that are in triage, because it's very fast paced and decision making. And a lot of our senior midwives that do cover triage are also very happy to do it. It took off so well. Nobody was opposed to it. None of the midwives in triage were opposed to it. Everybody was really happy that it just makes our process more fluid, and you know, it's just done as part of our assessment that we do for the women when they present.
Mm-hmm.
And it's decreased our waiting times. Ladies that come in with query ruptured membranes, preterm ruptured membranes, we can do all of that now. We can do the amnisure or the actin prom, depending on what tests we're using at the time, and do their monitoring, take the history, and if it's negative, they can go. There's no sitting around waiting for doctors. So it really does improve the way that we work in triage.
I'm just completely amazed that you found it really seamless and easy, because like me and Sophie and yourself earlier, we were talking, staffing is often an issue, isn't it? And I found that when we're trying to do any improvement or whatever, you train a small group of people, and then a third of your workforce is off sick. And how have you coped with staffing issues?
Well, I mean, there's always the one midwife in triage. It's irrelevant what's going on in labour ward. There will always be one midwife in triage. Triage doesn't close. It's open 24 hours a day. And it's, at the moment, we are only manned by one midwife. So staffing wise on labour ward doesn't really affect how we work in triage. What can affect how we work in triage is obviously how busy we are. And if we are really, really busy, we don't allow the fact that we haven't done a vaginal examination, a speculum, an FFN, an actin prom, a PV bleeding assessment. We don't let that delay our doctor's review. So if the midwife in triage is not in a position to be able to do the speculum there and then as part of that initial assessment, we will still call the doctor for the review and say, you know, unfortunately, we've been really busy, we haven't got around to doing speculum. And I think we have quite a really good working relationship with our doctors here. I think they appreciate how hard a triage midwife works. They can see how difficult it is, and you know, and 9 times out of 10, we will be able to do that as part of our assessment. It's just when, you know, 6 women will come through the door at once, and you're not able to keep up and do those speculums, those examinations, because other things have walked in that have taken priority. The doctors will always come and will always do the speculums themselves. It's no hard and fast rule who has to do it. We try and do it because it makes our life easier. But when we are in a position where we are too busy to, then the doctors are accepting that they come and do it.
Yeah, I'm finding in my triage where we're basically trying to improve to implement BSOTs. Do you use BSOTs? Zoe?
We did introduce BSOTs around the same time last year. We're trying. We are working towards it. It can be quite difficult because we are a busy triage, and we do just have the one midwife. So
yeah,
that one midwife needs to be the triage midwife and the treatment midwife. So that can prove difficult.
well, exactly. I think you hit the nail on the head in that, you know,
Yeah.
with BSOTs, I think we've set a really, really clear criteria as what safe care looks like.
Yeah.
And through using the BSOTs framework, we're then realizing that actually we're not hitting any of the targets, and we're not, and by definition, then we're not, and people get anxious about not hitting the targets.
Yeah, of course.
But then by definition, then we're not achieving safe care. And we're realizing that to have safe care, you actually need 2 triage midwives in triage. And yet at the same time, we don't have enough midwives to care for laboring women. So how are we going to put an extra midwife in triage? So it's really difficult.
It is difficult.
Yeah, Sophie, what are your thoughts about the staffing crisis, and how, you know, how we should approach trying to cope with all these demands for improvement and demands for efficiency savings? And I liked it in the first presentation where Charlie was talking about return on investment. I'm like, you know, that's not even in my radar yet. I'm just trying to keep everybody safe, let alone think about return on investment. What are your thoughts, Sophie?
Yeah, I guess return on investment is a good phrase, isn't it? And you know, that's what I was thinking when Zoe was just speaking. And I think, you know, so 2 points with regards to the sort of the staffing crisis that we have. I mean, sort of where we work, we've got a vacancy rate of about 20%, and that doesn't include maternity leave. And we know that there's difficulties, and it's not going to be resolved overnight, because we need to get midwives through their training and then qualified. But thinking about the project that Zoe has implemented, I can just imagine that actually you've got less women waiting, less women admitted, because if somebody comes in with query preterm labour, actually you can assess them. If they've got a UTI, then, you know, they've not been admitted, and that saves a bed on an antenatal ward, and the midwife getting busier and busier. So I guess that is your return on investment, isn't it? And I think how your improvement idea came about, you're just in triage thinking, you know, we've got these women waiting.
We need to find a way to make this quicker. Yeah.
And then it does make it efficient. So I think when you think about improvement projects, sometimes, and you know, they don't have to be massive projects. Like that was a small project, but actually, one, for the experience for the women, you know, they've not had to wait hours and hours. And I know some women self-discharge when they've been waiting, you know, for hours and not been seen. So the experience for the women is much better. And actually, if they are in preterm labour, then that helps escalate and transfer them to where is appropriate. And it helps the midwife's workload with patients not being in hospital when they don't need to be.
So we're starting to get some. We've spoken for 10 minutes now, so I'm wondering now might be a good time, because we're starting to get some questions as well. I mean, I'm not paying attention to the chat, but whoever's put anything on there, do you want to turn your cameras on and your mic on and just drop in? Because I think once you start speaking, you should pop into our screen as a speaker. So, you know, pretend, don't think of this as a Zoom call. Just pretend you're in the pub and you're drawing up the chair and you're kind of joining into the conversation. I'm really interested in hearing from any other midwives who might think that, be skeptical, because I've always just assumed that midwives might think this wasn't a good idea. You know, I've always assumed that. I've had pushback from midwives. I want them to put the prostin in the antenatal ward and they're 36+6, and they're like, oh no, we're not allowed to put the prostin in at 36+6, but tomorrow at midnight we are. So, you know, there's a bit of a cultural issue here, and what midwives are told they're allowed and not allowed to do. And I'm interested in hearing from other midwives in the room, because if Zoe's initiative is so simple, then why doesn't everybody just do this? Why didn't we do this like 10 years ago?
Because in relation to our professional registration, anything less than 37 weeks is preterm. and there's registration and accountability issues around that would be causing us to potentially breach our professional code of conduct. Discuss.
I think that's why it's so, yeah, I think that's why it's really important and critical what Zoe said about getting the SOP ratified and agreed, as in, you know, this is and I know different trusts, it's the same with regards to a PGD, isn't it? Different trusts have different patient group directives for prescriptions, and I think it's the same thing. It's about having a governance process that is really robust. It's been implemented, it's gone through that governance process. Everybody's been trained. So that's how you, you know, obviously if you're doing something that you haven't been trained in, that there's no governance procedure, then absolutely that's where accountability issues and issues with professional registration would absolutely come into question. But when you've gone through that governance process, I think hearing what you're saying, Zoe, I think why it works so well is because you've got such a small team.
We've got a small team and we're a set team, and we've all been experienced, we've all been, you know, qualified for a really long time.
I just spoke to Nicola regards to overtime.
Maybe Terry, if you could mute now, please. And I think Mercy and there's some other people in the chat. Just turn your mics on and your cameras on and just speak. Go for it.
Yeah, I'm Mercy. I just wanted to say that it's possible, and I was part of a midwifery team at St. Thomas's, then it was called ADU. We set up this system and it's been running for almost 20 years now, but I agree with Sophie. Number one of our criteria then, when I was there, I'm no longer there, but I will be going back. But one of the criteria was that you had to be a midwife who was qualified for more than 2 years. You had to be happy to work in the day assessment unit, because we did day assessment / triage together. And you would have training on everything. So all the speculums from 18 weeks onwards were done by the midwives. We did all the amnisures, the fetal fibronectin, unless it was contour indicated. So yes, it did save a lot of time. So I heard one of the speakers say it was down to your PIN. If you have the backing of your organization and you have the appropriate training, then you don't need to worry about your PIN, because NMC says as long as you're appropriately trained in any procedure, then you can undertake it. And so what we used to do is have a competency document, so the midwives would be signed off as competent, and that would cover them. And like Zoe said, so if you had to get a midwife from a different area that hadn't gone through the process, then they were not permitted to practice in that way.
That's great, Mercy. I want to just stay on with your camera on for a minute, because I'm interested in hearing your view, and anybody else as well, because what I'm hearing from you and what Sophie's just said is quite sensibly, if you have a governance structure, if you've got education, if you've got everything in place, then you can test, and all of us know this. But what I feel inside me is that we're always being told we have to do this extra thing, and now we have to do this, and now we have to add this extra thing that you have to do. And I think Nandiran is saying in the chat as well that, you know, you're already understaffed, you're already busy with dealing all the term assessments, and then now the doctors are telling me I have to do all the preterm assessments as well. There's an element of kind of cognitive overload that I think our staff are feeling at the moment, and I feel it, you know, and I really love improvement, and yet I feel really fatigued all the time now. When someone comes up to me and says, I've got this idea, I'm just like, no, I don't want any more ideas, because the energy it takes to do an idea or test an idea and like do anything is so much more than just coping with the status quo. And we know the status quo is not good. We know the status quo is not good for women and not good for staff and waiting times, etc. But yet just that energy it takes to do improvement is so much, to do the training, to do the staff, to get the SOP, to get the assurances, to get all the stakeholders. It's so much work. And I wondered how the three of you here and anybody else, please turn your camera on and chip in here. How do we protect our staff from this there's overload and their well-being. You know, I don't have any answers. I just want to discuss this, and maybe I know we don't have time. Got one more speaker, don't we? So maybe we can just round up in the next few minutes, Sophie.
Yeah, and no, I was just going to jump in. I just think Jane Sandel, she just put another good point in the chat, and she was just saying, why not think about the tasks midwives are doing that does not necessarily need a midwife? And I think that's really talking about the development of our maternity support workers. And when you think about, you know, transitional care, for example, they're usually band 4s, not midwives. And actually that's been a real shift from midwives looking after those babies and but
Sophie, the midwives actually retain professional accountability for those staff. So while somebody else may be doing the tasks, the critical analysis and the accountability remains with the midwife.
No,
so,
of course,
you know,
but we're just talking about, I guess it's about thinking about how we share the workload, how we can just make everybody's working life and working environment you know, that much easier, because we all completely understand that it's difficult times that everybody's working in at the moment, and I think
and we need to put women at the center of our care. And I hear what Sabrina said about the challenges midwifery particularly has faced and is facing, and will continue to face because of the demographics. And you know, taking on you know, we really need to focus on what our roles are, especially if we're to meet the Ockenden requirements and maintain our overview and not continue to fragment our role in ways. I do see actually we do need, is the services that don't support us doing our job, and how services are actually set up in terms of process. And are we clear as a profession about what we can continue to capably do, bearing in mind the challenges and the pressures that are going to come at all of us now and into the future because of the requirements to keep women safe, which has always been the case.
Terry, I actually think that for the midwives who engage in it, it's actually very positive for them and for the women, because I used to see it as a one-stop shop for women, because they come in, they don't have to see a doctor, a midwife, a sonographer, then a consultant. They come in and one midwife will do everything for them, take their bloods, do their CTG, do their speculum. And actually, I would argue that it actually saves time and you don't need an extra midwife, because a lot of times when a woman needs a speculum, for example, the midwife still spends her time setting up the trolley, fetching and getting things and putting the woman in position. So it actually saves time, and it's very rewarding for the midwife running one-stop shop.
And
so
I agree.
It's a win-win for the woman. It's safer. There's no handing over. There's no I forgot this or I forgot that. And it's very rewarding for the midwife.
I'm just going to interrupt you, Mercy, in the interest of time. And I totally take on board what you're saying, and with Terry as well. And I think the point as well is that, you know, you need to test different models of working, and the whole testing, designing, engaging thing is really, it's time consuming. It needs dedicated resource to do co-design properly with patients. Like we heard from our previous speaker, I think it was Rosie, you need a dedicated person who's paid. And Marina's put a really useful comment in the chat about how we have all these national programs now. They're all named different things. They have slightly different measures, and I welcome having nationally agreed measures and what we're supposed to be doing with smoking cessation, etc. But at the same time, we're investing in all these programs, and actually what we just need is just not basic numbers of staff. And this is what the maternity staffing crisis is all about. You know, until you have safe number of admin staff, no more vacancy in admin, no more vacancy in your HCAs, no more vacancy in your midwife, that you can reshuffle all you like, you know, the job roles and upskill your midwifery support workers, but you don't have enough of them. you don't have enough midwives. That's the basic problem that we're having
And the other
now.
problem, Sabrina, is, as I'm sure a lot of my midwifery colleagues will testify, we're not paid enough either. I mean, to have a midwife as a band 6 with all that experience, Mercy, who would be very capable of undertaking those. And I completely, the sense of fulfillment in doing that and using time efficiently, but they are not being paid enough to do all of that at the moment. So there's the element of pay as well for those
Thank you.
midwives.
Yeah, thanks, Terry. I'm just going to move us on just strictly for time. And I think, you know, what you're sort of hinting at, Terry, is just about well-being as well. And I think it's really important that, you know, in these difficult times, we're sort of all looking after each other and thinking about our well-being as well. So thank you, Terry. Good point. So I know Olivia's finally joined us. Olivia had a power cut at the real inopportune moment, as per, I mean, that is just the law. That's how the law of the universe works. So Olivia is going to be talking about optimization, right place of birth. So we're so pleased that your power's back on now, Olivia. So over to you.
Thank you very much, and huge apologies to everybody. That's my third power cut in 2 weeks, but the last one went on for 28 hours, so I should be grateful that that was just a short one. So if we could just go to the main slide, next slide, please. Lovely. So I wanted to talk to you today about, I'm Olivia, by the way, I'm the transformation lead midwife at the London regional team. And I'm leading on the intrauterine transfer project for the London region, which is part of what I want to talk about today. But I also just want to talk a little bit wider about right place of birth, because one of the things I've really noticed over the last 6 months is how many of the work streams we're all involved in come back to right place of birth, and quite a few of our work streams are approaching it from different angles. So I just wanted to make a small attempt today to bring that back. My slides have vanished. Do you want me to screen share instead?
Hi Olivia, I'm just trying to share my screen again. It's okay, I should be able to do it. Just bear with me one second.
No, that's fine. If you want me to screen share, just shout and I can do that. I will just up. Okay, fantastic. I think we're back on. So just a bit what right place of birth means. It's about having the right professionals that are unique to the woman's needs and her situation and that of her baby. It's about the clinicians in the room having the right experience, access to the right equipment, that the right discussion and consent has taken place with the service user about where they want to give birth and where will be the most appropriate place, and that they have given their consent after the correct information being given and being given the opportunity to ask questions, that the right person is making the decision about the place of the birth, and that is the woman or birthing person who is giving birth following discussion and information, and that on the occasions where birth doesn't happen in the right place, that there's the right incident reporting and the right investigation and the right sharing of learning from that. And all of that comes into what the right place of birth means. Next slide, please. So I just want to talk a little bit about the intrauterine transfer process, which is one of the big QI activities we're engaged in at the moment. Intrauterine transfer is required when a woman or pregnant person is anticipated to deliver a baby at the early gestation of under 27 weeks and requires expertise in facilities not available at the local unit, or occasionally where the local unit doesn't have capacity. The purpose of an intrauterine transfer is to essentially avoid an ex utero transfer, which is where the baby of a gestation of under 27 weeks is moved after birth, very soon after birth. And these are associated with increased neonatal morbidity and mortality. And most ex utero transfers represent missed opportunities for in utero transfers. Next slide, please. So the Pan London Intrauterine Transfer Implementation Project launched in September 2020 and had the goal of increasing the proportion of births under 27 weeks in the London region, which occurred in a maternity unit co-located of one of London's 8 neonatal intensive care units, tertiary centres. The national target for babies of this gestation being born in these tertiary units is 85%. London has historically experienced significant barriers in attaining that. The pilot launched in 2020 aimed to not just increase the proportion of births in the right place, but also to increase the efficiency of the pathway, reduce the burden on the clinician's time of ringing round and trying to negotiate these transfers. It was a collaborative process bringing in a lot of key stakeholders, including the regional team, the neonatal ODN, the LMSs, obstetric and neonatal voices in the room, the maternal clinical network, and the emergency bed service at London Ambulance. The process placed EBS, the emergency bed service, at the centre of the intrauterine transfer process. It produced matching performers, which EBS, the requesting and potential receiving units would all use to streamline communication, and it created a pathway in which EBS would make a single phone call to NICU at the potential receiving unit and receive a single phone call back within an hour with a decision, thus vastly cutting down on the amount of clinician time wasted in the process. Next slide, please. Gemma, sorry, next slide. Sorry, I don't know if that one's duplicated. Lovely, thank you. At the time the pilot was launched, exception reporting was commenced alongside it to detect cases where the intrauterine transfer process didn't work out. Initial data was really promising, with births in the right place of rates of 92%, 93% and 86% for October to December 2020. The really crucial thing about this is it can be done. It is done in other parts of the country, but also we did it here for the first 2 months of the project. However, subsequently, some deterioration in that rate of success has been noted. The 85% target has only been reached across London in 4 of the last 12 months leading up to March 2022. Obviously, there's been a pandemic. Obviously, there's been significant staffing operational pressures. However, it was felt by everyone involved in the pilot that the reason why the intrauterine transfer project wasn't working quite as well as we wanted it to be went deeper than simply transient staffing and operational pressures, and that there were other things we could do to make the system more resilient in the face of operational and staffing pressure. As such, in October 2021, we launched a QI project to investigate how the IUT process was going and look at change ideas for its improvement. Next slide, please. The reason, by the way, there are babies at the bottom of each one of these slides is not just to break up the monotonous green, but also because I think one of the really important things about QI, and it's coming back to what the previous speaker was saying about change fatigue, which is a very real thing, is all the time with IUT, I want everyone to keep in mind these tiny, tiny, tiny babies and the phenomenal difference which birth in the right place can mean for their outcomes, and what it means for us as professionals to be able to say to parents, your child is in the place where we can do the most for them, and everything that can be done for your child is being done. And that's what a successful IUT means. So the babies are there as a very, very permanent reminder of that goal. Next slide, please. So what did we do? Stakeholder outreach with key groups was undertaken throughout November and December 21. These sessions were structured around encouraging participants to collectively map the intrauterine transfer pathway together and walk through it, which is a classic QI technique. QI improvement methodology was then used to categorise the relevant themes and suggest appropriate interventions and change ideas. The key things we found while talking to consultants, to Band 7 delivery suite sisters, to Band 7 senior NICU nurses, were inconsistency in awareness and familiarity with the IUT pathway, particularly with how communication was intended to flow through the pathway and the roles and responsibilities of the particular clinicians within it at different times. There was a real absence of a sustained culture of ownership, in that it was everybody's job in every trust, in every role, in every banding, in every discipline, to try to find a way to find these babies to the right place for them to deliver. There was a lack of escalation for EBS to follow in the case of repeated declines, and they were left in the position of making multiple call rounds to the same units asking the same question. And there was also a limitation on the data collected and our ability to facilitate reviews, scrutiny, and thorough investigation and learning following failed transfers. Next slide, please. I'm happy to share these diagrams. I'm not going to go through this in detail because of time, but this is the fishbone diagram of the problems that we identified with the IUT pathway during the investigation stage and the stakeholder engagement. A fishbone diagram, for anyone who's not familiar, is a QI tool where you group the themes of the problems into bones of the fish, like technology, environment, method, process, people, data, culture. And then you have little miniature bones, the kind that you miss when you're deboning a fish and get stuck in your teeth, to collate the little problems connected to that. Just move to the next slide, please. Thank you. And again, I'm not going to go into this in detail, but I'm very happy to share it. This is the driver diagram we produced following that stakeholder engagement with the primary drivers, secondary drivers, and change ideas that we wanted to see. Next slide, please. So we're working on a couple of things at the moment. Everything is largely drawing from the new guidance, which I am drafting at the moment. This is guidance which intends to promote timely intrauterine transfers for women and pregnant people, again, decrease the amount of time arranging transfers, establish pan-London standards for providers, networks and systems in regard to participation in and awareness of the IUT pathway, set out clear expectations for recording the accountability of clinician decision-making, and outline a new pathway of escalation if an offer of IUT has not been achieved within a reasonable time frame. It also sets out clear expectations for trusts, LMSs, ICSs, and the regional team in regards to reporting, investigation, and sharing of safety intelligence. I'm really excited about the new guidelines. They've been reviewed by the intrauterine transfer implementation team so far. I'm in the process of aligning them with the maternity escalation guidelines that one of my colleagues on the regional team are writing. And they're going to involve a new role for the ICS surge hubs, which is really exciting. I'm hoping they're going to be ready for general viewing very, very soon. We just need to make sure that the ICSs are happy with the role that we're hoping they're going to play in this process. And as soon as we can share them for general comment, I will do so. Can I have the next slide, please? Right, so that is IUT, and I think I've got about 1 or 2 more minutes. I'm just going to really quickly go through right place of birth from a slightly different angle, but one that could not be more current. The Ockington report, the interim report in 2020, highlighted the need for a thorough and ongoing risk assessment of the correct place of birth as one of the key obstetric and midwifery issues identified in their report. They discussed a number of cases where there appeared to be little or no discussion of the appropriate place of birth for an individual woman or birthing person, and where there was limited evidence of joint decision-making or informed consent about the process. Significantly connected to this, there was evidence from their interviews of women and birthing people and their families that it was never discussed or explained to them thoroughly what transfer times might be to an obstetric-led unit in the place of complication, or whether indeed birth outside the obstetric-led unit would be an appropriate recommendation for that woman. I repeat recommendation because, as I went back to the beginning, the correct person to make a decision about the right place of birth is an informed woman or birthing person. Just move to the next slide, please. So the interim report in 2020 made a number of essential and immediate actions connected to the right place of birth. Number 5 was risk assessment throughout pregnancy, that staff must ensure that women undergo a full risk assessment at every contact throughout the pregnancy pathway to ensure that the recommended place of birth is still appropriate for the needs of her and her baby. Number 7, immediate and essential action, was that all trusts should ensure that women have ready access to accurate information to enable informed choice about the right place of birth, including a choice for the right place of birth being in theatres with a caesarean section. Next slide, please. The most recent Ockington report, which came out at the end of March 2020, meant to say 2022, apologies, also explored a number of case examples within which inappropriate analysis and recommendations of the correct place of birth were significant factors in poor outcome. It also listed a number of essential and immediate actions connected to right place of birth. Number 8 discussed complex antenatal care and made recommendations for LMSs, maternal medicine systems and trusts to support access to preconception care, provide services and follow national guidance for women or birthing people with hypertension, diabetes, or experiencing multiple pregnancy, advising them through this process on what the right place of birth might be for them. Number 9 referred to the obligation on LMSs, commissioners and trusts to work collaboratively to manage women at high risk of preterm birth and implement Saving Babies' Lives thoroughly. That action particularly links very closely to the intrauterine transfer project in London and the capacity we might have to do preventative work in this area by recommending where women might want to book for their pregnancy and have their care at an earlier stage. And number 10 referred to accurate information on transfer times for births outside obstetric units to be communicated clearly to women. Next slide, please. I'm going to whiz through this because I'm aware we've got 8 minutes left for the meeting, but these are just some linked initiatives going on within maternity at the moment, which link very closely to right place of birth, the personalised care agenda and the fantastic training being organised by my colleague Davika, the continuity of care agenda, the digital and data transformation project, interpretation for women who don't speak English fluently, the preterm birth networks and the CNST programme and its requirements for trust to put into place recorded discussions with women about the right place of birth for them. Next slide, please. Yes, that's the end of it for me. Gemma, you can stop screen sharing now if that's okay.
Thanks, Olivia.
I hope I didn't run over too much, sorry.
No, don't worry. There's a couple of really good questions coming up in the chat, so I think we should just try to answer those. So, and a couple of them are on similar points. So Aniko was asking, following Northwest London difficulties, one thing the current guidance isn't reflecting that she thinks exception reporting would be when you've needed to transfer to a tertiary centre within your own network and you haven't been able to, and then a tertiary centre outside of your network has taken the baby. And I think somebody else, it was a similar question. So many questions for you, Olivia. You'll have to sort of go through them all in the chat. Yes, so Grenville said, good point. Other networks, and the same as ours, have agreed in principle that a refusal of an in utero transfer should only happen if the maternity services or neonatal services are on red, and on that basis, if the woman walked into hospital anyway, she would have to be admitted. So yeah, just if you could respond to those couple of questions.
No, absolutely. The new guidance, and as I mentioned in my talk, one of the things the new guidance is aiming to do is to align itself very closely with the maternity escalation policy, which my colleague is working on at the moment, which very much sets out expectations for trusts and maternity units when they report themselves to be green, amber and red, both in terms of what we expect from them, but also in terms of the support that they can expect to receive at those statuses. Because we feel there needs to be far more in that area. And the new IUT guidelines are going to make very clear what the expectations for a tertiary unit within a system who is reporting green, particularly, to be able to do. The whole pathway is going, assigned to the new guidance, is going to put far more in place for reviewing what happened when intrauterine transfers are not successful, and the new data recording devices that we're going to be bringing in at the same time that are attached in appendices to the new guidance are going to collect a far more thorough set of data, which means I think we'll be able to extract safety intelligence from these reviews far better and put changes in place. Because I feel at the moment, essentially, you can get into a situation where the EBS calls and calls and calls and calls again, but actually the intelligence of at what moments during that process people could perhaps have made a different decision are really lost and can't be followed up very easily. And that's what the new guidance is really looking to change.
That's great. I just have a question, Olivia, about the new guidance, and I don't know. Last year I did a deep dive review into the neonatal deaths that we had in Greenwich, and a significant proportion of those were obviously associated with extreme prematurity. And when I reviewed the cases, a couple of things that I noticed were some of the women that had delivered at sort of the extremes of prematurity. We're a level 2 unit where I work, were extremely high risk, previous history of preterm birth. Some had cervical stitches, had admissions with PV bleeding. And I was sort of thinking, my sort of thought process when I was reviewing these cases was similar to sort of stroke services. If you're high risk for a stroke or you've got symptoms of a stroke, you wouldn't go to a DDH, you would go straight to a tertiary centre. And I know it's really difficult, isn't it? Because lots of women do present with threatened preterm labour, and obviously they're not in preterm labour. But I just wondered, is there anything for the women who we know are extremely high risk for preterm birth, the women that have had, say, 2 mid-trimester losses before they've got a cervical stitch in, and they call up, so they call the triage with, I've got abdominal pain and bleeding. I just find that sometimes there's a delay in, those women then come to the DDHs, get assessed, and then we have to go through the IUT process. And I just wondered whether we could sort of think, and I know there's complexities with that, but whether we could think about whether we can align ourselves with sort of stroke services in that kind of setup.
Yeah, no, absolutely. I think preventative work is an enormous part of this solution. And that's very much why I didn't come here today and just do it. I didn't read correct place of birth as please just talk about the IUTQI project, because I think it's so vital to tie this work in with the personalised care, with continuity, with risk assessment at each contact about, is the plan for this woman still the right plan for this woman, or could we be doing something else? With the work that the preterm birth networks and the clinical networks and the maternal medicine networks are doing, and the Ockington requirements around preterm birth, these are all part of preventative measures that stop a woman getting into the intrauterine transfer pathway to start with, because she could actually be where she needs to be. So I think there's going to be a lot in the guidance and in the surrounding education material about preventative work and triaging, and perhaps if a woman is under the care of preterm birth networks earlier on. Perhaps a discussion about whether she does need to be booked with a tertiary unit is all part of the discussion, because all of these work streams I've mentioned are pulling to that same goal of everybody taking collective responsibility for looking at every woman and birthing person and saying, do we have the right plan in place for you, or do we need to make modifications to make this safer for you? And that's what I really tried to do in this presentation today, bringing all of those work streams together.
That's fantastic, thank you. And I was really intently listening to you and to comments coming up in the chat as well. So I'll let you go through those, Olivia, because I think I might have missed a couple of questions, but just for time rise, really interesting, thank you. So I don't know, just before we sort of round up and finish off, if everybody, and we've still got quite a few people on the call, so thank you for staying this length of time on a busy afternoon. If you could all pop back on your cameras. Gosh, there's loads of people still on the call, which is fantastic. So what I was just going to say, for those of you that are happy that have put on your, it's nice to see everybody's faces, and thank you for participating in this afternoon. What we're going to do in a second is just talk about a quick evaluation and how you would like, obviously it was our first Pan London event, how you would like these to, you know, we very much want these for you guys. I'll hand over to Gemma in a second. What we would like to do is just take a screenshot for our social media. So for those of you that are not happy, or if you haven't popped to the hairdressers, you can turn your cameras off, but those that are happy, if you don't mind just, you know, putting on your best smiley face. Are you screenshotting, Gemma?
Yeah, screenshotting now. Everybody smile, 3, 2, 1. Thanks so much.
Thank you so much. So an evaluation is just going to pop up in a second. If you wouldn't mind all filling in the evaluation. I've certainly learned some tech issues as we've gone along, so apologies for those, but I think that is the world that we're living in now with Teams and Zoom. And I'm just going to hand over to Gemma and Omid. I think they're going to talk about how we want these events to pan out in the future.
Thank you, Sophie. Yeah, thank you so much everybody who joined today. As Sophie said, it's our first Pan London event. So we're really keen to get feedback on how we can design these events going forward so that they're really useful for you who are joining. We've spoken a little bit about the MatNeoSIP program today, but we have our optimization work stream and our duration work stream that the national team spoke a little bit about. But we're here really to support you in your roles at the Trust and to help wherever we can. So we are keen to get your feedback so we can, work with you going forward. Thank you.
Could I just say a huge thanks to Sophie for presenting, to all of our presenters who've shared content, and to Gemma, Paulina and Lewis. Without you guys, we wouldn't have had this event. So thank you very much.
Thanks, Omid. There's just somebody's asked if you could email the questionnaires. They have another meeting to go to, but obviously somebody does want to feedback. So it would be really, your evaluation is really important to us. And somebody's already had emails and chats popping in, and somebody's already emailed me with a suggested topic for the future, which is great. So any improvement work that you are working on, any ideas that you've got, please do share it with us in the evaluation, because we do want this to be sort of collaborative working. And it's just so great that we've got so many different trusts, not even within our sector, across London, which is fantastic. So thank you. It's 5 o'clock. I'm sure you've all got to rush off, and it's half term. So it's great that we've had such a good turnout during half term. So thank you so much, everybody. And thank you to all the speakers, and have a lovely evening.
Thank you so much. And we will share the recording of this as well.